Good day, friends. Today we are going to discuss a topic which is very common, causing lots of anxiety and has lots and lots of misunderstandings. But before that, let us start, as usual, with a prayer.
Start audio.
When we face a feeling of being lost, that is the time we require guides and we require guidelines. Today's talk is a re-recording of a talk which I gave at the annual conference of OG Society of Bangladesh. It's a recent lecture, and I am sure it will be of great clinical help to you. These guidelines for the management of adolescent PCOS. When you want to discuss guidelines, you have to go deep and you have to dig deep. And there are multiple sources from where the nectar I have got ready for you. And these are my sources from where this digging has been done and the guidelines have been identified and the common areas are going to be put before you. Polycystic ovarian syndrome or polycystic ovarian disease is a most common endocrine condition and affects between 8 to 13% of women of reproductive age. That's a huge absolute number. And 6 to 18% of adolescent girls. Coming events cast their shadows before they come. Just 5 minutes before, I have reviewed a case of adolescent PCOS where the child was least bothered, but the mother was hyper worried. And therefore, our fundamentals should be very clear. WHO says that adolescence is the period between 10 to 19 years of age, which includes significant and critical changes in growth, development, and puberty. Now, something very basic I would like to touch here. For the diagnosis of PCOS during adolescence, mark my words, clinically, both irregular menstrual cycles and hyperandrogenism needs to be present. So you will ask me that in that case, how do you define irregular menstruation? Well, the challenge lies in not getting mistaken by patterns of a maturing HPO axis. This is where many times we overtreat and we tend to wrongly label these adolescent girls as having some challenge or a problem, when actually it is just a normal physiology. So now let me ask you a question. Ms. A, 10 years of age, her menstrual cycles are irregular. She walks into your clinic and gives a history of menarche of 1 year. Should you start investigating for PCOS? No. Only 1 year? No. Miss A, 13 years of age, has irregular menstrual cycles, menarche for about 4 years now. Should we start investigating for PCOS? And this is where I have seen maximum confusion. Maximum over-treatment comes here, over-diagnosis comes here. These are not cases of PCOS as yet, as per the guidelines. But they are introducing a new term, that is, they are at risk of developing a PCO or manifesting a PCO. And last, Ms. A, 18 years of age, as irregular menstrual cycles, menarche for about 9 years. Should we start investigating them for PCOS? Yes. Yes. So this is where you can clearly differentiate. One more, which guidelines tells us not to do. And this is going to disturb many of you because we have become so dependent on it. And that is, pelvic ultrasound should not be used for the diagnosis of PCOS in those with gynecological age of less than 8 years. And this term, I'm introducing to you one more after at risk, and that is gynecological age. What is a gynecological age? You will read this many times in pediatric references or pediatric journals. Those subjects with the duration of time post-menarche. So if she is post-menarche less than 8 years, her gynecological age is less than 8 years. This should not be used for diagnosis. Therefore, the last situation which I gave, where I used the word 9 years, will you investigate? Yes, but not with ultrasound. Why so? Because till that time, there is a high incidence of multifollicular ovaries, even normal at this stage in life. Also, the maximum ovarian volume is reached by around 20 years of chronological age, which will be around 8 years or more of her gynecological age. Therefore, it is unwise to use ultrasound for a diagnosis of PCOS in adolescents. So the question now for you is, for you a very important weapon in the armamentarium has been removed, and that is your ultrasound. You have become so dependent on ultrasound. There is a solution in the guidelines. With ultrasound not being recommended for diagnosis of adolescent PCOS, the two pillars that we have to rely on for a definitive diagnosis of PCOS in adolescents are: 1, clinical hyperandrogenism, and 2, laboratory hyperandrogenism. Now let us see what will you label it as clinical hyperandrogenism. Severe acne and hirsutism, these two features. Now what do you consider as acne which is severe or noteworthy? More than 10 acne on her face, more than 10, I repeat, is clinical evidence of hyperandrogenism. And by the Ferriman-Galway score, which we used to memorize when we used to appear for our MD exam, if it is more than or equal to 4, between 4 and 6, this is indicating clinical hyperandrogenism. What about laboratory diagnosis? There also there is a confusion, and I would like to clarify with the help of these guidelines. The recommended are, by the guidelines, calculated free testosterone, free androgen index, or bioavailable testosterone. DHEAS is to be used only if one of these three or all of these three are inconclusive. Whereas your so much used FSH-LH ratio is not recommended for diagnosis of PCOS in adolescents. In such a situation, you will always argue for a reliable friend which we have been started using recently in non-adolescent subjects for diagnosis of PCOS, and that is anti-Mullerian hormone. What about that, sir? I have been asked this. Anti-Mullerian hormone in adolescents and adult women with both polycystic morphology and a full-fledged PCOS are significantly higher, but there is a significant overlap in levels. Therefore, its reliability as of now is a little less. With improved standardization of assays and established cutoff levels based on large population of different ages and ethnicities, AMH assays will become more accurate and will be more reliable in detection of PCOS morphology. But as of now, it is not included in the guidelines. I introduce you to the term at risk. Let us touch this a little. Who are adolescents who are at risk? For adolescents who have features of PCOS but do not meet the diagnostic criteria are to be labeled as PCOS at risk. The timing for them is 3 years post-menarche or 3 years gynecological age in relation to menstrual cycle irregularity, and 8 years post-menarche in relation to the use of pelvic ultrasound to identify a PCOS morphology. So, for an adolescent PCOS, if you want to use menstrual irregularity for clinical diagnosis, then 3 years at least she should be post-menarche. And if you want to use ultrasound, then she should be at least 8 years post-menarche. Then you can use these two parameters for diagnosis of PCOS. Till then, they are at risk. We now come to the treatment part of it. And there comes emotional wellness. And I am including this very early. The reason being, we are very casual about it, or we are not well aware of it. That PCOS, there is a very high prevalence of moderate to severe anxiety and depressive symptoms with increased prevalence in adolescents. Also, anxiety and depressive symptoms therefore requires to be routinely screened for in women with PCOS when you label that diagnosis. Recent studies in women with PCOS indicate an increased prevalence of disordered eating, and the international guidelines provide recommendation for awareness, assessment, and appropriate therapy in adolescent PCOS. This should be now added to your armamentarium when you approach an adolescent for treatment of PCOS. Something which I have found most consistent in giving results in PCOS, and this is now for nearly 11 years, papers are getting published. In the treatment of PCOS, the most consistent results, like these two great players in football, are giving most consistent results, and that is lifestyle interventions. We tend to run it down because we are programmed to drug treatment. Even our patients are in these cases not patients, but their mothers or their parents or their guardians are interested in drug treatment, treatment of drug. We should have a very clear perception that drug treatment comes last. Very important is lifestyle intervention. Multi-component, including diet, less sedentary behavior, exercise, and behavioral strategies should be recommended in all those with PCOS and excess weight to achieve reduction in weight, central adiposity, and insulin resistance. Are we not expecting too much from an adolescent girl to do all these? Yes. Therefore, the family should intervene. I am aware of families who have changed their lifestyles. Mothers or fathers or brothers going with their wards to gyms, going with their parents or with their sisters or daughters to a dietitian, and not only stopping at that, when they are sitting on the dining table, they themselves have stopped consuming foods or food articles which increase adiposity. The entire family, and in them, I have seen miraculous results. The mother just doesn't cook. The mother just doesn't buy these foods. The father refuses to take sweets. The father or the brother cooperates maximum, then this young girl will be motivated. Gone are the days when parents used to teach children about virtuous lives, about how not to fail, how to be successful, how to study, all these things more. Now, these things are assured. Success is assured. Children are going to study. Now, these are the things which we will have to teach, or the next generation of parents will have to teach their children about diet, about exercises, about healthy lifestyles, about how to deal with failures. All these things are now new curriculum of new generation parents. Weight gain is the number one priority expressed by young women with PCOS. What does it show? It shows that she is ready. Now we have to make or develop an environment which is conducive to her losing weight. I am now going to introduce you to one vicious circle which has been found, though it has not found a very solid space in guidelines, but all guidelines hint at a bidirectional association between PCOS and weight gain. That means obesity may induce PCOS by worsening its features in susceptible individuals, and PCOS invites obesity. This raises a concept of secondary PCOS. However, it is still far from defined, but I am introducing you to this secondary PCOS. In adolescents, therefore, with PCOS, a multidisciplinary model of care is more effective, with a dietitian, health psychologist, and endocrinologist, all combined with dietary intervention compared to receiving neither or dietary advice only. No, a comprehensive care, and that has to be managed by the gynecologist. So gynecologist is the manager here. What about the drugs? Quite a few of different sizes, different colors are there, which are scientific to use as per the guidelines. The COCP, combined oral contraceptive pills, estrogen and progestin preparations. The COCP alone should be considered in adolescents with a clear diagnosis of PCOS, or could be considered in those deemed even at risk for the clinical management of clinical hyperandrogenism and or irregular menstrual cycle. Many times we receive patients in whom estrogen progesterone preparations have been started. But with estrogen progesterone, COCPs with 35 micrograms of ethinyl estradiol is fine, and a proportionate progesterone. But 35 micrograms of ethinyl estradiol with cyproterone acetate is something which became very popular in between, but as per the guidelines should not be used, howsoever strong the evidence of clinical hirsutism is, but should not be used as first-line therapy due to absence of evidence of greater efficacy than COCPs, but has a higher risk. One more, very interesting, and that is metformin. I was told that metformin should be a routine in adolescents, but there are some guidelines who tell that if there is clinical evidence of insulin resistance, then you may. Whereas some others say that there should be a laboratory proof of insulin resistance before you start metformin. I leave it to the practitioners to decide it on case-to-case basis. Metformin, in addition to lifestyle interventions, could be considered in adolescents with a clear PCOS diagnosis or with symptoms even before the diagnosis is made, that at-risk group. Metformin, a dose of 1700 to 2000 milligrams per day, was associated with an improved BMI when compared with COCP. And what about the gastrointestinal side effects, which is most complained to or most by other gynecologists? Only 5 RCTs have reported it out of nearly 23 which showed the efficacy. What about the combination? COCP and metformin. The COCP in combination with metformin can be considered in adolescents with PCOS and a BMI of more than 25 kilograms per square meters, where the COCP alone or COCP and lifestyle changes, which should always be a combination, has not achieved desired goals. No only COCP. Lifestyle changes are must. A natural question which you would like to ask is, what about anti-androgens? When you are speaking so much about hyperandrogenemia, let us at the end touch anti-androgens. Recommendations suggest that the use of COCP alone with cosmetic therapy for at least 6 months be done prior to considering anti-androgens. Where COCPs are contraindicated or poorly tolerated and in presence of effective forms of contraception, anti-androgens could be considered to treat hirsutism or androgen-related alopecia. That's all. Only these 2 indications. So friends, to sum up, you can label, and I have seen at many places this label for adolescents. They are high risk for many problems, but low risk or low priority, for the society, most of the societies. And what does that lead to? That leads to mismanagement of all their problems, including health problems, which includes adolescent PCOS. How to avoid it? How to limit it? Follow the guidelines. Guidelines are your reliable friends. If you follow the guidelines well, then adolescents will do what they are destined to, fly free and reach newer heights, soar to newer heights, because her health problems have been taken care of. Now she is invited to fly.